We're just very, very excited to be moving into our second of the 2016 webinar series. And today we welcome you to the second of our 2016 SiNERGe CBO Collaborative Webinar Series. My name is Grace Bigelow, and I am the SiNERGe Community-Based Organization Outreach Coordinator and will be moderating today's session. With these presentations, we are hoping to provide the most current information on a variety of topics of particular interest to the sickle cell community. We hope to target a lay audience, thus having the content be very accessible to all, patients, family members, caregivers, and the wider sickle cell community. Of course, we always welcome suggestions from all of you on topics that you would like to learn about or people you'd particularly like to hear from. We're excited to move this series forward. We will continue in the theme of living well with sickle cell, focusing today in our session on living with the pain of sickle cell disease. So today we have living with the pain of sickle cell disease, myths, realities, and hope. We are very privileged this morning to have the highly esteemed Dr. Wally Smith presenting on living with the pain of sickle cell, a topic he has been researching, talking about, and advocating for a better understanding of for many years. Following his presentation, his research manager will discuss, his research program manager, will discuss the study they are now conducting, SHIP-HU, on the benefits of patient navigators. We hope their presentations will both inform and inspire us, hopefully galvanizing us as we resolve to continue working towards improving the lives of those living with sickle cell disease, as well as improving the relationship between those living with sickle cell, their families, and the healthcare system. The presentations will be followed by hopefully robust question and answer period as time allows. We ask you submit your questions in writing on your computer screen, and I will read as many questions as we have time for to the presenters for their response. The views expressed by presenters are their own and do not necessarily reflect the views or opinions of the William E. Proudford Sickle Cell Fund, the SiNERGe Project, or associated parties. This webinar is for informational purposes only. Individuals seeking medical advice should always see a qualified health professional. And now it is my pleasure to introduce our first speaker, Dr. Wally Smith. Dr. Smith is the Florence Neal Cooper Smith Professor of Sickle Cell Disease, a member of the Federal Intra-Agent Pain Research Coordinating Committee, and Vice Chair for Research of the Division of General Medicine at Virginia Commonwealth University. He has held nearly 50 grants, including the NIH-funded Pain and Sickle Cell Epidemiology Study, known as PISES, as principal investigator, the Cooperative Study of Sickle Cell Disease, a multi-center study of hydroxyurea in sickle cell disease, the Sickle Cell Disease Clinical Research Network, VCU was the site, VCU site principal investigator, the Sickle Cell Disease Outcomes Research Network as principal investigator, and the NIH-funded VCU Basic and Translational Research Program, BTRP, in sickle cell disease as principal investigator. Dr. Smith has been associated with the development of 2 potential lead compounds for sickle cell disease at VCU. He has been extraordinarily successful at recruitment of sickle cell patients into clinical research, enrolling over 450 patients in 10 years. His latest NIH-funded project grant, SHIP-HU, randomizes patients to receive patient navigators to enhance patients' adherence to hydroxyurea treatment. Welcome, Dr. Smith.
Thank you, Grace, and I'm glad to be a part of this topic today. For decades, I think people have endured, patients and their families, misunderstandings, myths surrounding the pain of sickle cell disease. Some of them, in fact, created by the very research that we were doing. Others as a result of stereotypes held by physicians and community members. Next slide. These are my disclosures. Next. Most of you know that pain and sickle cell disease is the hallmark of the disease, that it occurs anywhere that there's an artery and a nerve to sense ischemia. It's present throughout your life. It's variable in frequency and intensity, and only partly explained by what we know about the severity of sickle cell disease on the genetic side. Next. So today, what I'd like to do is to try to clear up some of these myths and misperceptions, talk about what we know about what pain really is and how it's experienced and the types of pain that patients with sickle cell disease have, the frequency of their pain, the need for pain therapy, and the prevalence of addiction, which is much lower than what is thought. Next. Pain in sickle cell disease is bad enough that it causes a lot of visits to the emergency department. In the magenta slide, you can see the patients who are sometimes disparagingly called good sicklers. They don't come to the emergency room that much, don't come to the hospital that much. And then the other half of the slide, you can see what are disparagingly called high, well, the word was frequent flyers, and we were recently chastised for using that word actually as a slip of the lip at a conference. But you can see patients use the emergency department and the hospital 7, 8, 9, 10, 11 times a year, 12, 13 times a year when their pain is really severe. Next. The perception is that the use of the emergency department is all there is, that the use of the hospital is all there is. It is tied up with one reality, and that reality is the more you use the emergency room or use the hospital, seen in green here on this slide, the less likely you are to survive. The survival probability goes down significantly if you're one of those people in the wrong half of that circle that I just showed. If you don't use very much, shown in yellow, then you live longer. And so that led to the idea that the more pain people have, the less likely they are to live. That's not quite right. Next. So the perception was that these people in the top half of the circle that I showed you, that there's something wrong psychiatrically or psychologically, and they're also not going to live as long. And these names that I talked about have been used to describe these patients. It's just wrong, but it was somewhat based in the fact that survival is tied to how many times you come to the emergency department. Next. Keep going. So here are the realities. We've learned recently that pain in sickle cell disease is not just what you experienced in the emergency department or in the hospital. In fact, it's often invisible to caregivers. It has no physical correlates. There's no lab tests. There's no physical finding. We don't have a painometer. There's nothing we can do to determine whether a person with sickle cell disease is in pain or how severe their pain is, even based on whether they come to the hospital or not. We know that pain induces an entire panoply of secondary responses: emotional distress, fear of the pain, fear that people won't believe the pain, social withdrawal. Our patients, as we try to find them in this SHIP-HU study, don't want to be found. They sort of say the old thing that we learned in the South: I can do bad all by myself. And they don't want anybody to try to help them out of their misery because they've been living with it so long that they've come up with coping mechanisms all on their own. So relief seeking, therefore, often involves self-management and family assistance. We did a study once, and patients named the two most common coping mechanisms as alcohol and God. Prayer and alcohol. How funny is that? Next. Another thing about pain and sickle cell disease is that we've gotten all distorted in the language that we use to describe pain. It's not clear, not even clear among researchers what we mean. It's certainly not clear when you talk to patients. Patients have learned how to use this word crisis to describe their pain, but there's not a very clear definition of what a crisis is, except when the patient says they're in a crisis, we mark it down that way. As a result, pain in sickle cell disease, even significant pain, when it's not called a crisis, can often not be measured, not be mentioned to the caregiver, and therefore vastly under-recognized. Next. This leads to under-treatment, and the patients then get upset because the doctor says, well, you're not in a crisis. Why should I give you opioids? Next. And it also leads to understudy. So some of the earlier research that we did has led to the perception that pain in sickle cell disease is not common and therefore not worthy of more description and more study. Next. So these two kinds of terms, the terms from the patient's perspective, and they just talk about pain, and then the terms from the researcher's perspective can lead to a real dilemma. And some of our research has helped to clear that up, but not completely. Next. So think of pain in sickle cell disease as an iceberg. The part that's above water is the part that patients actually come to the hospital for. So the tip of the iceberg is seen in the hospital by healthcare providers and emergency departments and hospitals, and it's fairly infrequent. But most of the pain experienced by patients with sickle cell disease is actually experienced at home, and patients will be the first to tell you they go to work with their pain, they go to school with their pain, they do childcare with their pain, they cope with their pain. The implications of this are vast and lead to the idea that many of the patients with sickle cell disease actually have what's called chronic pain syndrome. That's an entirely different animal than the idea of periodic pain that requires coming to the hospital or coming to the emergency department, interceded or intertwined with no pain at all. So you can imagine if somebody was in pain most of the time versus not in pain most of the time, how their life would be different. And in fact, many of the patients are that way. Next. So our study, the Pisces study, was able to show this in living color. So there is an iceberg of pain in sickle cell disease. On the days that people are in the hospital or in the emergency department, their mean pain intensity level is about 6.5. On the days when they're in a crisis, but not in the hospital, it's still bad. It's about a 5.5. And you can see that's 13% of the days, over 3 times as many days, they're in a crisis that they named a crisis, but they didn't bother to come to the hospital. And then beside that, there's patients who are just in their, quote, normal sickle cell pain. That's still bad. It's 4.2 on a scale of 0 to 9. And that's about 40% of days. So patients are in pain most of the time with sickle cell disease. Next. What kind of pain is it? Well, they use lots of descriptors. And one of the types of descriptors they use describes a kind of pain in sickle cell disease that's never been really proven before, and that's called neuropathic pain, pain due to damage to the nerves themselves. We always thought of pain in sickle cell disease as due to lack of oxygen to a specific organ, and one of the organs could be the nerves, could be the muscles, and that the pain that we were seeing in sickle cell disease was just like tying a tourniquet around your arm. That might be some of it, but it doesn't appear to be all of it. And that's what this study began to show. Next. Now, this is an important slide. Even if you cure sickle cell disease with a bone marrow transplant, you don't immediately get rid of the pain of sickle cell disease the way you would expect if all of the pain were just due to a crisis and due to the tourniquet-like sensation that you get when you cut off blood circulation. It takes as much as 12, 16 weeks on the horizontal axis for the pain to actually get better and the patient to not need opioids to manage their pain anymore. That suggests the types of pain that patients have with sickle cell disease are far different than what might have been thought before, and that reversing this type of pain is not a matter of simply stopping the sickling process. Next. Also, if you treat with hydroxyurea, and that's the people in the brown line, the very high group, and you get a good response to hydroxyurea. For those who don't know, hydroxyurea is the only anti-sickling medication we have. It's a shame. It's the disease, it's over 100 years old, and we have exactly one drug for it. But if you give that drug and you give adequate amounts and patients respond well, they still have a significant amount of pain. And only if they extremely respond well do you get a significant reduction. I think you can see that the people in yellow who are low responders, the people in blue who are moderate responders, did not have much different in intensity of pain than the people in blue and the people in pink who were the placebo. Next. Pain in sickle cell disease is related to geography, so it matters where you live. If you live in the north, in the southern, in the colder climates, you're going to have a little bit more pain frequency than if you live in other regions. You live in the south, you tend to do better. People in Jamaica, people in the islands seem to do pretty well. There's a famous researcher named Graham Sargent who described pain in sickle cell disease, and you would have thought that opioids were not necessary because not a lot of patients were on opioids. In the United States, where it's colder, patients get more pain and more of them are on opioids. Next. Another strange thing, pain in sickle cell disease is often bilateral and often multi-location. And this was a part of the Pisces study. So just to walk you through this, the second bullet shows that there were 15,563 diaries that we collected among patients over a 6-month period. And on each of those diaries, we showed where pain was located. And they could draw on those diaries and show us exactly where they were hurting. On those days, an average of 11% of the boxes that they could check off or draw in were checked off, and an average of 3.3 of the 16 possible sites, that is 21%, were marked as painful. Next. And the pain was predominantly bilateral. So if you had left arm pain or left ankle pain or left foot pain, it was also in the right. If you had left shin pain, it was also in the right, and so forth. So you can see here that predominantly the pain was bilateral. And in many cases, it was a large percentage of patients, 70, 80, 90% of patients who had bilateral pain. And that's strange because you wouldn't expect blood to be equally clotted off or obstructed in each arm or each leg. So again, it suggests something other than just oxygen deprivation must be going on to explain the pain of sickle cell disease. Next. So I think we've shown that pain in sickle cell disease is very, very common. It can be up to daily. About 30% of patients in the Pisces study said they hurt every day. We've shown that it's variable. And I think that demonstrates that we need another type of treatment paradigm than simply what you do in the emergency department or do in the hospital. It also demonstrates that we need to figure out where this pain is coming from and not just assume that it's coming from sickling, but maybe it's coming from other sources and we need to treat those sources. Next. Now, what do patients do in response to this pain? This will be familiar to any patients that are listening. The typical thing is to get really still. Go somewhere, lay down, don't move too much, maybe talk, or maybe be very quiet. It can go either way. I had a patient in clinic yesterday who had really severe pain in her leg, and she was rubbing her leg. She was rubbing it constantly and kind of groaning. And I felt very, very sorry that I couldn't make it go away. Tried to give her some comfort in the clinic, but of course we had to end up sending this patient down to the emergency room. People worry about how they're being perceived when they have pain and sickle cell disease. What will my relatives think of me? What will the doctors think of me? What will the church people say about me if I try to go to church? They worry about moving around. Sometimes they cry and they lament. Even when they're not in a crisis, they cry and they lament about having to go through one more crisis, not knowing when it's going to happen again. And again, a lot of social withdrawal. People talk in whispers about sickle cell disease. It's not out of the closet the way HIV/AIDS is, even in 2016. Next. What kind of things do they do to actually relieve their pain? Well, here's some very common things that patients report. I use heat. Some people actually use cold. Kind of strange, but they actually use cold instead of heat. I use massage. I try to sleep. I talk to people. Doctors don't understand that when patients are on the phone on rounds in the hospital during a crisis, that does not mean they're ready to go home. That means they're using distraction therapy to get their mind off of their pain and looking for some physical and emotional comfort from others. People rely on families to help with their children, washing the clothes, cleaning the house, and things like that. I have lots of single moms who rely on their older kids to help with the child care duties when they're in a crisis. And these kids have been schooled in how to help mama through when she's having a hard time. If all else fails, they break down and they actually go see a doctor. And I'm laughing because that's the way they describe it. I hate going to the emergency room. When I'm there, I have given up. I've tried everything I could do at home, and there's nothing left for me to do. So I'm turning myself over to you, even though you may not treat me right. Next. So in reality, patients have to get opioids and be treated with opioids. And we know that opioids have a problem that they don't work the same after 10, 20 years. That's because the receptor where the opioids bind actually changes its response when the opioid binds on the receptor. So without getting into too much science, the word tolerance is also called immunity, is also called resistance. It just means that what used to work doesn't work anymore. And if you're 20, 30 years old with sickle cell disease, and you've been getting so-called narcotics for all those years, they may not work as well as they used to when you were 10. Some people have to take these things every day. Now that produces what some doctors wrongly call addiction. But I want to distinguish addiction from physical dependence. All physical dependence means is that you're biologically required to keep the medication on board, or else you will have withdrawal. That by itself does not mean that you are psychologically addicted and that you will kill to get more, or that you are using it for pleasure, or that you are using it when you don't have pain. So a number of the patients who have to take everyday narcotics, everyday opioids, do have this physical dependence. We have made the decision in my clinic that that is tolerable if that is what it takes to keep people at work, keep people mobile, keep people doing their activities of daily living and running their families. Some patients don't think it's worth it, but the patients who do we steadily supply them with doses of opioids every day, and they get some relief from those doses and do not lapse into this addiction as a rule. Next. All right, what about the people who are really addicted? We don't know the real answer to that, but it's certainly not more than in the general population. And you can see that the estimated prevalence of addiction in people with pain in general is all over the map. So nobody knows what percent of patients, not just with sickle cell disease, but with any pain syndrome, are really addicted. The measurement tools are not that good. But let's just assume that it's as high as 19%. That's still lower than some surveys have recorded physicians' beliefs about addiction. Those surveys suggest that physicians believe 50% of patients with sickle cell disease are addicted. Next. This is a complicated slide, but I want to just show that people are using different kinds of combinations of painkillers. The yellow is people who are on long-acting opioid painkillers. For those who are familiar with MS-Contin, fentanyl, methadone, OxyContin, these are the patients who are on that, and you can see it's on the order of 20-some% of patients. Then there are a number of people who just use short-acting narcotics. And it's a large number of people like that. But you can start to see the parallel. You got these people up here, they generally correspond with the people that I told you are in pain every day. These people in general are in less pain. And then you got people who don't need narcotics at all. And you have the rare bird who needs no pain medicine at all and is doing just fine. Next. Concentrate on the yellow here. This is the comparison of pain in people who use opioids and are on hydroxyurea, the only anti-cyclic medicine that we have, compared to people who do not. And the point I'm making here is that 98% of the people who use opioids are also bad enough that they're also on hydroxyurea. Whereas 81% of the people on opioids are, I got that backwards, let's get it right. 81% of the people versus 98% of the people who are on opioids are not using hydroxyurea. The point is, if you need opioids badly, you also are likely to be on hydroxyurea. Next. Now, this is a very important slide. The Pisces study was able to prove once and for all that just because you come to the hospital a lot doesn't mean that you're using narcotics more. So again, that myth about the people who show up at the hospital all the time in the wrong half of that circle that I showed you are something like addicted or psychologically impaired or using their opioids too much. That's not what we discovered. In fact, 35% of the Pisces patients would have fallen into that nasty term, frequent flyer. But they did not use opioids more frequently than the other patients. So what that tells me is people are deciding whether or not to come to the hospital, but because they had access to their pain medicine, sometimes deciding to stay home and suffer and do bad all by themselves. And I think that's a very important point, that you can't make a blanket statement or disparaging remark about somebody who comes to the hospital all the time and say they're here to get their pain medicine. Next. Also, we recently did a study where another candidate drug, which treats acute crises, was used, and we were able to show that on that drug, the use of opioids dropped dramatically. Never mind the unit of analysis here, but everybody can see the difference between 12.9 and 57.9. This is the sugar pill. This is the real drug. And the idea here is that within the first 24 hours, this drug was able to knock out the need for opioids. That's important because it validates that the pain in sickle cell disease is real, can be treated by something that knocks sickling out, and as a result, does not lead to more use of opioids when the pain is not there. So it validates the pain scale, it validates the patient's pain is real, and it validates that patients are not just drug seeking. Next. I'm not going to read this entire slide, but we asked a particularly well-informed patient. This is a person who has the disease, but who's also a sickle cell researcher. We said, should you just be giving opioids to patients in the emergency room and in the hospital? Or should you allow patients to use opioids in anticipation of their pain at home and when they need to in the moment at home without a doctor saying it's okay to take 3 pills instead of 2? And I'll summarize by saying this person said, yes, you should allow patients to make decisions about how much pain medicine they take at home on their own and give and trust them enough to not misuse the pain medicine. Next. The same patient was asked, okay, so let me just ask you, do you sometimes use the pain medicine in anticipation that pain is going to occur? And he said, yes, the second bullet. I tend to do it when I have something important or something that I've been looking forward to on the horizon. Just as you phrased it, I try to head off the crisis by taking more meds. And I will tell you, that's what patients tell me too. And I say to them, good for you. You avoided an emergency room visit. You avoided a hospitalization. Many doctors, however, would think that that's a bad move and that you shouldn't use medicines before you actually feel the pain. We also tried to ask, do you have an aura? Do you know when a crisis is about to come? Not 100% of people get that, but some actually do. They could say, I can tell a crisis is coming on. Next. Another study asked patients, now tell me how you're really taking your meds. Dr. Smith isn't going to know. The research assistant closes the door, and the patient's just talking to a tape recorder and talk about how they're using their medications. And what we learned is there's overuse and there's underuse of narcotics depending on what's written on the bottle and what the patients actually do. And you can see all the reasons around the circle here why people decide to hold off. These make plenty of sense to me, but I can tell you that they kind of go against what the expectations are for how patients should be using these in the current environment. So for example, if you have a family meeting that you're going to and you don't want anybody to see you look drowsy, you're going to hold off using your narcotics and grit and bear the pain. That makes sense to me. Next slide. On the other hand, if you're like that researcher and you're anticipating that something's going to go wrong, you might use more than what the bottle says to use. For example, you're concerned about not getting your work done. You don't want to lose your job. You may medicate up to make it through the shift, or you might medicate up in order to get some sleep so that you can get up and go to work the next day. That makes sense to me. But again, these reasons for overuse have generated lots of consternation and accusatory statements by physicians. Next. I'll just let you read some of these. Yeah, I stopped taking it. I was worried about becoming dependent. Yeah, it slows me down. If I got stuff to do, I don't take it. Yeah, if I take it, the kids steal the money out of my purse. They go to the store. All kinds of reasons why people over or underuse according to what's written on the bottle. So I kind of have stopped chastising people, especially on their long-acting medication, for not using it according to what's written on the bottle. And I've tried to say to them, I want to give you enough medication so that if you get into trouble and you were trying to avoid coming to the hospital, you can do so. And I will leave it up to you whether you actually take it the way it's written on the bottle or not. And it's eliminated a lot of tension, believe it or not. The trust that I have for the patients is rewarded with patients telling me what they actually do. And I begin to trust them even more. Next. I could talk a long time about sleep and sickle cell disease. I can tell you it's really complicated. The medications probably disturb your sleep cycle. A poor sleep cycle probably makes pain worse. Worse pain makes you want to go to sleep, but maybe not able to go to sleep. We're still beginning to understand this. It's true in children. It's true in adults. Next. People who are in pain are also tired. They're tired because they didn't sleep, but they're also tired because they're anemic. And so the pain of sickle cell disease, the anemia of sickle cell disease, the fatigue of sickle cell disease are all vastly conflated with one another. We did an FDA special panel on patients' belief about pain and sickle cell disease. The half that made it there rated pain as their major symptom. The half that didn't make it there rated fatigue as their major symptom. They were too tired to come. Next. Not surprisingly, quality of life in sickle cell disease is terrible, somewhat worse than in asthma, cystic fibrosis, and about that of patients with dialysis. Next. This word catastrophizing just is one of the psychological responses to pain and sickle cell disease. It's the oh my God syndrome. I'm about to have a crisis. The world's coming to an end. This could be terrible. Not everybody does this, but when you do it, it's not really good because it tends to make things worse. But we have patients who do it, and this just is a study that proved that. Next. This one's interesting. This is called somatizing. And basically, this is about bodily distress as an expression of psychosocial distress. We're starting to understand better that when your mind is sick, your body can get sick. And this is basically a study that's starting to show that. So your boyfriend and you had a fight, or you had a death in the family. Of course, that's going to somehow affect your pain in sickle cell disease. Next. And this is the one about fear of movement, which I've already talked to. So again, it is present. This is just a study that shows that it is. Next. We could talk days and days about this, and I've already implied that trust between sickle cell patients and the doctors in the hospitals and emergency room is bad bilaterally. The patients don't like coming. The doctors don't like to see them. Negative attitudes abound. Medical care opinions are poor. Disputes break out sometimes between patients and staff. The number one complaint of patients when you get them together in a federal setting is, can you all please make the doctors treat us right? Next. So I've talked a whole lot about the kinds of pain that patients have with sickle cell disease, the fact that it's not all from crisis due to oxygen depletion. There's probably some other types of pain. I talked about hospitalization not being the only expression of pain in sickle cell disease. I hope I've convinced you that pain in sickle cell disease is basically around all the time for some patients, and that it's mostly treated at home, and that therefore the doctors and the researchers vastly underappreciate and undermeasure and undertreat the pain. I told you about how often you heard sometimes predicts how long you're going to live, and that we don't really understand what happens from kids to adulthood, but something is going on that changes the pain from merely being ischemia to maybe being some kind of nerve damage. And then some other disorders, which I didn't talk about, but if you know anything about chronic fatigue syndrome, irritable bowel syndrome, most of these disorders share this nerve damage problem that sickle cell disease has. So sickle cell disease may be like other diseases, is that after a while you hurt so much that your nerves get damaged and you hurt automatically, so to speak. Next. I talked about opioids, and we're still learning about them. We talked about the only drug we have and the response to hydroxyurea, and also the new drug we're working on and the response to that. I made a big point about emergency room use not being associated with more opioid use, and I made a big point about fatigue and sleep quality being parts of the expression of pain in sickle cell disease. So let me stop there and then turn the podium back over to Grace, who's going to introduce Shirley.
Okay, thank you very much, Dr. Smith. Can everyone hear me? Okay, so now we will turn to Ms. Shirley Johnson. Shirley Johnson has been a licensed social worker for over 20 years, having served individuals with severe disabilities, mental illness, and child abuse. She has developed a foundation-funded transition program for VCU SCD patients ages 15 to 21, of which she received statewide and national exposure. She has been the research program manager on a grant funded through NHLBI, a demonstration multi-site project testing the use of patient navigators to enhance medication compliance for those with sickle cell disease for the past 4 years. She was instrumental in the development and implementation of the training of this project and oversees all aspects of the grant, as well as a HRSA grant and the overall department manager of all sickle cell disease investigations. She's been conducting clinical and translational studies directed to better understanding of sickle cell pain and its management. She has published many peer-reviewed papers and reviews on the subject. Today, Ms. Johnson will discuss SHIP-HU patient navigators, research that is being used to track the benefits of a patient navigator with the chronically ill population. They work in both the academic clinical environment and the community home environment. Welcome, Ms. Johnson.
Thank you so much, Grace. Next slide, please. So what I wanted to talk about is our project and how it relates to what Dr. Smith was just speaking about. As a licensed social worker and working with this population for the past 7 years, I knew that there was a need to do more than what we were doing in the clinical setting for patients. And I felt that we needed to have an outreach program that also collaborated with the academic medical centers to try to assist patients more in not only navigating their medical care, but assisting them with all other aspects of psychosocial dynamics that they may be facing. Therefore, we applied for a grant from the NHLBI and were fortunate enough to be the first R18 demonstration project funded for sickle cell disease by the NHLBI to test the use of patient navigators. So what I mean when I look at this slide and I say we are different because we are the only known program where research is being used to track the benefits of a patient navigator with a chronically ill population. We developed the training program for the navigators where we speak with them about not only the aspects of sickle cell disease, the importance of hydration, the importance of taking their medication like hydroxyurea, learning how to speak with their physicians, but also trying to really empower them through the time that the navigator is working with them. So we do a 4-day didactic training program, which I will talk about in a little bit, which will help you understand how we feel very comfortable about the navigators going out and working with the patients and having the appropriate information for them. As I stated, we are housed here at VCU, and we work in conjunction with the medical team as well as the community. But the interesting part about this is because it's a study, our providers are not aware of who has a navigator and who does not that is enrolled in this program. Next slide, please. So the patient navigators are very important in helping to bridge the gap between the clinical provider and the community. As most of you are well aware, physicians have limited time that they're able to really spend with the patient to figure out maybe why they are not being able to be compliant with their medication. For example, if a mother is coming to the clinic appointment, she's been having a lot of difficulties maybe paying her rent or keeping her utilities on, or her children are having problems in school. Many, psychosocial elements that many families face. The physician may not necessarily be aware of those because they just don't have the time to put into that to find out why the patient is struggling so much with taking their medication. So in this case, we're able to be the assistant to the physician, even though they don't know who has a navigator, to try to be able to help that patient become more able to be self-sufficient with their medical care. So the navigators are also instrumental in providing resources to our patients. We have developed an extensive resource binder from our patient navigators being out in the communities all around the state of Virginia, indicating what resources may be available to them. We are in the process right now of updating that resource binder, and we try to continuously do that in case our patients come to our navigators and say, we need to contact somebody regarding legal aid, we need to find out about housing, and we have all the appropriate information to provide to them. We also want to focus a great deal on the disease itself, and we educate them on the CDC guidelines that have been established for patients with sickle cell disease. We work extensively to help them understand the importance of hydroxyurea, and like Dr. Smith said, because it's unfortunately the only approved drug that we have, how it can benefit them in helping to stay out of the emergency room in the hospital and have a better quality of life. Next slide, please. So our training program, like I stated, is 4 days of didactic training where we educate the patient on the sickle cell disease and the use of hydroxyurea. And we have physicians who not only work here at VCU, but one of our consultants, Dr. Lautenberg, who has come in and educated the navigators, which is a videotape training program that we now use for other new hires that come into the program so that they're all getting consistent information. We also speak with them a great deal about how to properly communicate with the patient and try to get the patient to really speak more about what they may be going through that day than providing yes and no answers, and that's called motivational interviewing. Again, we also focus on the importance of health maintenance, how you need to take your medication, how you need to make sure you're dressing appropriately for changes in the weather, how important it is for you to stay hydrated, and any other health maintenance issues that the patients may have. Of course, we're very protective of the confidentiality of the patient, and that is something that we really focus on here, just like other providers do around the country. And like I stated earlier, we also are there to provide resources for them in the community. Next slide, please. So the role of the patient navigator is to develop a relationship with patients, assist them in building trust not only with the navigator, but hopefully with the medical system as well, educate them on the needs for ongoing medical care, community resources like I stated previously, gene education, and what I mean by this is making sure that patients with the disease understand maybe how they inherited the disease, and also for them to move forward when they are preparing for their own families, of knowing the genotype of their significant other, and also becoming more confident in coming into their medical appointments with information to help better manage their care with their provider. We also want them to, again, enhance their understanding of their disease, and as I stated previously, we work on providing materials to them and educational resources to help them really understand the importance of the things that they need to talk with their provider about when they come in and meet with them. And we review these materials throughout the 1 year that the navigator is assigned to them so that that navigator and the patient both feel confident about what they've been able to learn from working with one another. Next slide, please. So some of the barriers that we have been facing in our program, like most providers around the country, is the navigators can only do so much. So they may have information to be able to provide the patient, but sometimes the external resources are not necessarily available to the navigator or to the patient themselves. So what we're hoping to establish through this program is to continue to work with outside resources to help them be able to help us better identify what we can do for patients when they come to us with these problems. I think this is going to be an ongoing process like it is for other hospitals who are working with sickle cell patients, because resources are very limited out there. We all know that there's maybe housing issues for patients, and because they don't necessarily qualify all for Social Security disability, they might not be able to get into subsidized housing, which would help them maybe better manage their care. We also know that there may be issues with them for their children in school, and that we need to be able to provide better advocacy for them if they're not able to do so on their own, so that their children are getting their needs met, which reduces the stress for the parents. We also want to make sure that if patients are suffering from depression or any other mental health problems, that we are able to refer them to the appropriate providers so that they can get the care that they need as well as treat their sickle cell disease. So this is just a general idea of how we feel we need to work in the community to better get them, to better have the community understand the sickle cell patients and what some of their needs may be, as well as somewhere down the road, this program may be helping other patients with chronic illnesses. Next slide, please. So my goal at this point is to try to move forward to continue funding for the Patient Navigator program. We are in year 4 of a 5-year grant, and we're hoping that we will be able to continue to write other grants that will help sustain the Navigator component for this program, as well as being able to provide certification in the state of Virginia for navigators so that we could possibly get Medicaid reimbursement. Like I had stated previously, we also want to continue to build resources within each state that we are working with on other grants so that they can in turn work with sickle cell patients and continue to provide them the support that they need. And also to improve and enhance the training that we have. We've learned a great deal over the last 3 years of working with this Navigator program and how we have been able to change the way the Navigator has worked with patients. So our curriculum that we developed does need to have some fine-tuning to it, which we are going to work on in the near future, so that we can continue to enhance the role of the Navigator with the patient. And I think that's where I stop here.
Okay, thank you so much, Ms. Johnson. I do have a couple of questions, and there is, if folks notice on their screens, computer screens, there is a little chat window. We don't have a lot of time, so I have a question first for Dr. Smith, and one of our participants is just wondering how treatment being described is different for children, particularly because most opioids are not approved for use in children.
Yeah, most drugs are not approved for use in children. So opioids join a long list of drugs not so approved. Children have the fortunate prospect of not having received opioids early on, most of them, and therefore being extraordinarily sensitive to opioids when they're first given. This is an important thing because as time goes along, one of the slides I showed, patients develop tolerance. So we do the same thing, just a lot less of it in children as we do in adults. So until hydroxyurea came along, and now hydroxyurea, also not approved in children, is being given to children. Until that came along, it was opioids, supportive care, fluids for crises, and when possible, less potent analgesics such as Motrin and Aleve and things like that for mild pain. So we progressively increase the treatment as the pain demands it.
Thank you very much. I do have another question, and this one is directed toward Ms. Johnson. And she asks, the participant asks how they can get in contact with the resource binder. This person is in Virginia and eligible, and wondering if they are eligible for the resources listed, housing specifically.
What I would suggest is I can provide my phone number, and that person can get in touch with me. And depending on the circumstances, we may be able to even have one of our navigators reach out and assist that person with some of the questions they may have. Our resource binder is not actually in a printed stage where we can provide it to anyone, but we have resources that we might be able to direct them to via email or whatever makes them feel more comfortable to try to assist them with that.
Thanks so much, and I'll make sure that the two of you are connected after we get off today's webinar. I have another question. I met with a 30-year-old male that refused to take hydroxyurea because of the side effects, specifically sterility.
Yeah, sterility is the extreme and rare side effect that scares many people away from hydroxyurea. More commonly, though, is low sperm count, which is reversible. Now, the rates of that are not yet clear. The fact that it exists is pretty clear. And I can tell you many, many males who stopped taking hydroxyurea for a while were able to impregnate somebody and got back on it. So it is not as scary as it sounds or as frequent as it sounds, although it's real. And if a 30-year-old says, I'm afraid of it, I would not force that person to do it because they have some facts to stand on. On the other hand, I explain that to patients, and most patients, when they hear the speech that I just gave, elect to go ahead and take the drug and get benefit from it, and then stop when they want to plan a family.
Great. Thank you so much, Dr. Smith. And then another question. I'm interested in hearing how the 1 year time frame for, the 1 year time frame for patient navigation was determined, and also whether ideally outside of the research setting, navigators would be able to work more closely with providers.
So we decided that when we were starting the grant, we had to limit some type of time frame for how long the navigator was going to be involved with the patient so that we could, of course, conduct our study and see whether or not there was benefits to the navigator. So when the patient decides to enroll into the study, they are possibly either randomized electronically to the navigator group or to a group what we call the passenger group. If they are navigated into the navigator group, then that navigator works with them for approximately 12 months. So we established that just as a criteria to try to gauge a time frame long enough for a navigator to possibly make an impact on the patient, but at the same time not extending it too long so that the patient doesn't have the navigator once they have to leave their role in being in the study. We also would like for further funding down the road to not have to be a study where a provider is blinded, because as we have talked about within our own internal mechanism here, in a typical situation when a navigator is having some concerns in relationship to a patient's health, we now have to be very clever in trying to get the answers that we need to for the patient without breaking the blind. So for example, we may go to another provider who's in the study who's not directly relating to this patient, such as maybe the pediatric provider or the other site provider, to try to get some information, whereas typically if you were not in the study, you would be going directly to the physician and having a one-on-one and trying to assist them with that. So our goal is, if we get extended funding through another resource, that it's not for the particular purpose of what we're doing now, and that we could have that ongoing relationship between the navigator, the patient, and provider without having to worry about the blind.
Okay. Thank you so much, Shirley. I am actually right now, it looks like we're at 12 o'clock. However, we do have a few additional questions. Ms. Johnson and Dr. Smith, are you able to stay on the call for a little bit?
Sure.
Okay, so what I'm going to do, I'm going to go ahead. I will obviously, this is being recorded. Any questions that we have answered or discussion that goes beyond 12 o'clock, for those that cannot stay on, I will make sure that that information is made available to you. The next question that we have is, I would like to hear more about how you think we can lessen physicians' views of addiction within this population.
Well, we have a national battle going. It's being played out in the news. It's being played out in federal guidelines that are coming down the pike. Most of you are aware that the Centers for Disease Control, the CDC, recently issued a guideline about prescribing narcotics in patients with chronic pain.
Mm-hmm.
It's being played out in offices of physicians across the country. You can go in a physician's office now and see a sign on the wall, "I do not prescribe narcotics. If you have pain and you want narcotics, go elsewhere."
Mm.
So we are in the middle of a culture war about the role of narcotics in chronic pain, and sickle cell disease is caught in the middle of that culture war.
Right. Yeah.
We are not going to solve this with evidence. This is religious in its intensity. I think we're going to solve it by understanding that we have to trust one another.
Hmm.
Patients have to trust that the doctors are going to do the right thing. They often do not, especially sickle cell patients, and for good reason. They've been treated badly in the past. Physicians have to trust that the patients are not going to misuse their medication and are going to take it the way it's prescribed. And you can't prove that no matter how many monitoring devices you have. We have computerized monitoring now. We know every pill that's being prescribed. We know what doctor prescribed it. But you can't watch everybody take their pill every day. So, I hope that this blows up enough and becomes such a public conversation that we get some sanity brought to bear in the argument. Otherwise, we're going to have this distrust that exists right now is going to continue to flame up, and we'll have patients at war with doctors, which is unfortunate.
Yes. Thank you, Dr. Smith. I have one more question. I also quickly want to just mention that we did have some people register from Tanzania, and one of those participants has put in a question, and I will follow up after the session. But I just wanted to let people know how our outreach has been so successful, and we are just thrilled to have people from all over here to join us today. The last question, we are curious as to whether you educate your patients on non-pharmacological techniques to manage pain as well.
I think both Shirley and I should talk about that. As a physician, my approach to so-called complementary and alternative medicine is to first do no harm. So if it reveals to me that they're using a complementary and alternative medicine, non-pharmacologic techniques, but also any pharmacologic techniques that are not prescribed by me or are part of what the normal doctor will prescribe, I say to them, as long as I find no harm with it, you're free to do it. I don't have a program of complementary and alternative medicine that I'm employing, but I'm learning. I'm beginning to learn about, for example, cognitive behavioral therapy, about acupuncture, about transcutaneous stimulation. I'm beginning to learn about these things that I did not learn in medical school, but which I'm beginning to see will make a difference in the lives of my patients. As I learn about them and employ them, I'm going to try to show that they actually benefit, because I think in sickle cell disease, there's a place for them.
Okay.
And
oops, I'm sorry. Go ahead, Shirley.
on our end over here, we are actually trying to work with a local school for massage therapies for our patients as well. So we're trying to see if we can get the hospital to coordinate time when the patient can come in, that they can actually get a complimentary massage, which we're hoping would help reduce some of their pain and some of their stress. So we, on our end, are also researching alternative mechanisms, and all of us agree that cognitive behavioral therapy is a really important tool, but we need to figure out how to make that work in our environment right now with some of the restrictions we have of getting patients into mental health care without the proper diagnosis, and also how to treat them when they're in the hospital when their primary issue is probably more of a depression mechanism than it is related to their sickle cell pain. So we are all aware of these issues and are doing our best to try to, again, build relationships in the community to help patients with alternative mechanisms to deal with their pain so they can try to reduce their opioid use.
Okay, thanks very much. Dr. Smith, we do have one last question, and this is from the person in Tanzania, and she is not familiar with the term opioid, and I responded to her directly just saying that it included such medications as methadone or OxyContin, and then that they are medicines that are opiate-based. And I just wanted to clarify with you if there's a better definition or a more comprehensive one.
Yeah, it comes from, of course, opium, and opium comes from the opium poppy, which I think many people are aware grows in the wild in certain parts of the East, and it's old as the hills, but sometimes not known by that term. Narcotic is the term in the United States that's used, and I try to stick with opioid because of the chemical implication. But
right.
That was a good enough definition for that person, and if they still don't understand, we can help them understand better.
Okay, I think it was good. And so now in conclusion, I just want to thank our speakers for their wonderful presentations and sharing both their expertise and experience with us to gain a better understanding of the complexities of sickle cell disease pain and approaches for treatment. It is clear more can be done to improve communication, understanding different treatment options to improve the quality of life and health outcomes for those living with sickle cell disease and their families. I just want to also thank all those who joined us today for their interest and commitment to the cause, as well as their thoughtful questions and comments. Please feel free to contact me for further information or contact info related to the webinar or any other topic of interest. We have recorded our session today and will make it available as soon as possible. We will also circulate a very brief 6 to 7 question survey, and we ask you all to take a moment to complete that. It'll probably go out in the early part of next week. It's a great tool as we move forward with the series. Again, thanks so much for being part of today's webinar, and we look forward to staying connected with all of you and continuing in our commitment to the entire sickle cell community. Thank you, everyone. Thanks so much.
Thank you.